And then again, more for special tests. Some of them are going to be provocative, meaning that you're trying to reproduce the symptoms, and some are going to be palliative, meaning that they're going to relieve the symptoms. So provocative are going to be, always if it's a body part that there's two of, always test the uninvolved side first and then the involved. If you're talking about the spine, obviously there's only one, so there's only one side to do. And usually provocative are either going to be compressing something or stretching something, and then palliative are usually to reduce the traction. So we'll talk about cervical compression, and we'll talk about cervical distraction. Other times we're going to recreate the mechanism of injury. Like I said, for shoulder dislocation, we're going to do that type of action that produced it. Isolate certain pathology, and we'll talk more about close pack position of a joint and loose pack position. So basically is when everything's all jammed together, and loose pack is where it's in a neutral position. Like here, this is the close pack. All the ligaments are stretched as much as they can. The joint is crunched together as much as it can, whereas the loose pack is going to be more of a neutral position. Most of the time, the loose pack position is if you're just kind of in a relaxed position like that. Like right now, this is pretty much all the loose pack positions of the joint upper extremity. Okay, close pack is when you start talking about more extreme type things. But in a general sense, whatever's a comfortable, relaxed position is going to be your open pack. And then with certain ligaments, if we're testing a ligament on this side here, stretch it, which way am I going to push my wrist? This way or that? So I'm going to stretch it here to the left. I'm going to go that way. And then we'll talk more about that, but basically what that is valgus. Anytime the distal part of the extremity moves away from the midline, it's valgus. When it moves towards, it's varus. I think that definition will probably be in there later. There'll be tests where we'll do some certain things in the neck, and we'll put the head in a certain position to try to compromise the vascularity. Or when we talk about thoracic outlet, there'll be certain tests where we're trying to provoke vascular symptoms. And then neurologic, like I said before, everybody remember the 3 different ways you test nerve tissue? You either traction or stretch the nerve, or you narrow the opening where it goes through, or you tap on it. And then the last objective thing is going to be laboratory or imaging tests, X-rays, MRIs, CTs, bone scans, things like that. Obviously, typically that's something that you're going to be doing, but you may be in contact with patients that have had those types of things. So again, it's like this where you're trying to zero in on the target, right? You start with layers and you're going in farther in, and you want to end up with a differential diagnosis based on clinical signs and symptoms, the physical exam, the mechanism of injury, and then the testing. So you narrow it down to 1 to 3 different possibilities. And then the plan, that's as far as what you're going to do about it. So you're going to talk about the treatment, what the goals are that you want to accomplish, what time frame you want it to occur in, how they're going to modify their activities, and then this HEP or home exercise program. And then also in some cases you need to refer somebody out. If there's a red flag or something is not right, you need to send them out. So now what we're going to do is start going into the spine. We're going to start with the neck. Basically for this class what we do is we go with the neck, and then it used to be that the thoracic outlet was handled separately, but a lot of the structures that we talked about relating to the neck also apply to the thoracic outlet. So we kind of do that together. So the neck and the thoracic outlet are going to be this week and next week. And then I think we go into the thoracic spine, and then after that we start going down the upper extremity. So in each case what we're going to do is do applied anatomy, talk about the anatomy of the area. I'm going to need the password again.
Yes.
I got to blur it out. So we'll talk about the anatomy of the area, And we'll talk about specific structures that are going to be applicable for that area as far as things that are going to apply to special tests that we're going to do. And then we'll talk about how to examine that given area. Okay, so we're starting on page 15. And then the way that the pattern is going to go when we talk about a certain area, we're going to start, we'll talk about the inert tissues. And again, everybody remember what that is? Bones, ligaments, bursa, basically things that don't contract. And then we'll talk about the contractile tissues, and then neurologic and vascular.
Where are the tendons?
Tendons are part of the contractile. Because basically contractile is muscles, tendons, and their attachments. So it could be anything from the actual muscle itself, the tendon, and then the spot where it attaches. Because when we talk about like tennis elbow, you have lateral epicondylitis, and you talk about shin splints, the problem is actually where the muscle tendon attaches to the bone. So again, like I said, we're going to talk about the inert tissues, bones, ligaments. And in this case, when we're talking about the spine, when we talk about the discs, that's basically going to be an inert tissue. The contractile and the neuro. So in the cervical spine, of course, we have 7 cervical vertebrae. And how many cervical nerves are there? 8 nerves. That's because the first one comes up out above C1, and then C8 comes down below C7. And from that point down on, when you name the nerves, it's based on the nerve comes out below the named vertebra. And then we have the 2 plexi in the cervical spine. You have the cervical plexus and the brachioplexus. Cervical is going to be C1 to C4, maybe C5. And then brachioplexus is going to be C5 to T1. Now, the brachioplexus is going to be more significant for our purposes. So like I said, when it comes to dermatomes, myotomes, reflexes, you pretty much want to know from C5 to T1. Then we have the anatomy of the cervical vertebra, starting with the occiput. So we have the articulation between the occiput and C1. And oh, that was the other thing I forgot to mention when we were watching that video. Because when you talk about the motion at the cervical spine, when you're nodding your head like this, you're pretty much doing occiput C1 or upper cervical. Okay. So when Victor was doing like this kind of thing, and nodding like that. So you talk about, when we talk cervical spine, we're going to divide it into upper cervical, which is going to be occiput C1, C2, and then lower cervical. Because it's almost 2 different areas, and they behave differently because of their facet planes and things like that. So basically here we're going to have, this is going to be the upper cervical here. Okay, so the motions that occur there are different than the rest of the cervical spine. So primarily what occurs at the occiput C1 is flexion extension. Because if you go like this, and you feel on your neck, most of the action is occurring up here. You're not doing your whole neck like that. It's just upper cervical primarily at the occiput. And then there's a little bit of lateral flexion that occurs at the occiput here, and not very much rotation. And then what's the significant thing about C1 is that there's no vertebral body. Basically, it's become part of the odontoid process of C2. And now this is where you have most of the rotation that occurs between C1 and C2. So when you're turning your head like this, most of it happens up there. Like if you feel on the side of your head, you can feel that most of the rotation is happening here. Down lower part of your neck, there's not much going on.